Criteria for cirrhotic cardiomyopathy and the future directions. This is the brief outline of my talk. Coming on to what is cirrhotic cardiomyopathy, its prevalence, and why it is important to investigate. Cirrhotic cardiomyopathy is basically defined as cardiac dysfunction in cirrhosis with no primary underlying cardiac disease. It has a typical pattern, which is hyperdynamic circulation at rest with the blunted chronotropic response to the stress, and characterized by diastolic dysfunction and electrophysiological changes, namely QTC prolongation. And there is a modern concept of cardiohepatic axis, that is a bidirectional liver-heart interaction affecting the outcome, especially during the stress time. How to define cirrhotic cardiomyopathy? It is a cardiac dysfunction in patients with cirrhosis, which is characterized by blunted contractile responsiveness to stress, altered diastolic relaxation, that is a stiff heart, QTC prolongation, and absence of any other cardiac disease. It is often clinically silent at rest, but unmarked during the hemodynamic stress, which can be sepsis, TRIPS, or transplant. So this basically shows the historical evolution of cirrhotic cardiomyopathy. Initially, it was reported by Kolsky et al. In 1953 as a hyperdynamic circulation, which is characterized by increased cardiac output and decrease in the systemic vascular resistance. Then we moved to the 2005 Montreal criteria, which relied heavily on the reduced LV ejection fraction and strength chronotropic competence. Then we have moved to 2019 CCM consortium criteria, which is the modern criteria, and which acknowledges the preserved liver ventricular ejection fraction but subtle systolic dysfunction, that is global longitudinal strain, and the advanced diastolic markers. And coming to the era of different phenotypes of CCM, namely ACLF, forward and backward failure, cardiohepatic axis, and the post tips and the post transplant outcome related to the cirrhotic cardiomyopathy. Why diagnosing the cardiomyopathy is important? This basically is a driver of the hepatorenal syndrome and AKI. It has been reported to approximately 7 to 21% of the post-transplant death and death post tips, and grade 3 diastolic dysfunction has been associated with a 2-year mortality of 40%. Coming on to the epidemiology, the reported prevalence rate widely ranges from 6 to 70% depending upon the cohort and the diagnostic criteria. New criteria often reduces the diastolic dysfunction. However, there is an increase in this prevalence with the systolic dysfunction, which is reported with the new criteria. The old criteria, the approximately prevalence ranges approximately 45 to 70%. And the standard diastolic dysfunction criteria on the American or the European Society, 30 to 40%. The CCM consortium criteria, the prevalence of the cirrhotic cardiomyopathy ranges from 25 to 55%, and only upon the strain imaging, that is global longitudinal strain, the prevalence increases up to 50%. The cirrhotic cardiomyopathy is often silent at rest and it decompensates under the stress. Cirrhotic cardiomyopathy can be seen up to 1/3 to 1/2 of the patient with cirrhosis, and when there is stress, which can be in form of TIPS, sepsis, it is unmarked. It affects it increases the risk of heart failure, pulmonary edema, or perioperative or early post-transplant mortality and heart failure. It affects the renal perfusion associated with waitlist event and mortality. It limits the use and titration of non-selective beta blocker and the other vasoconstrictor, and has been a target for risk stratification. It's a potentially modifiable factor. Coming on to the pathophysiology, the various molecular mechanisms that have been reported, the first is desensitized heart, which is basically because of the beta adrenergic dysfunction. The hallmark of cirrhotic cardiomyopathy is the inability of the heart to increase the heart rate and contractility appropriately. There is a chronic sympathetic overactivity. There's downregulation of the beta receptor, and there's a uncoupling of the G protein, and which leads to impaired chronotropic and inotropic competence. There's alteration in the cholesterol phospholipid ratio in the cardiomyocyte membrane, leading to the increased rigidity of the cell. The dysfunction of the potassium channel, there's leading to the downregulation of the potassium channel, leading to delayed repolarization, impaired L-type calcium channel, reducing the intracellular calcium transit and weakening contraction. There's an increase in the cardiodepressant, namely nitric oxide, endocannabinoids, and cytokine, which are the target for the future drugs, which is reported in cirrhotic cardiomyopathy. This basically summarizes in a cirrhotic liver, this portal hypertension, there is increase in NO-CO, endocannabinoids, there is splanchnic vasodilation, there is a reduction in the systemic vascular resistance, there is deformity of the titin and the upregulation of the alpha of the beta SC molecule, which promotes the myocardial fibrosis and the cellular defect, and basically it basically defines the pathophysiology of the cirrhotic cardiomyopathy. Coming on to the criteria, how we move from 2005 to 2019, that is the modern criteria. The old standard was dependent upon the systolic criteria, that is resting left ventricular ejection fraction of less than 55%, or blunted increase in the cardiac output, that is less than 10% on the stress test. However, the problem was it was load dependent and low systemic vascular resistance, and loads the heart, artificially boosting the left ventricular ejection fraction. And similarly, the diastolic criteria depend upon the E/A ratio, which is basically the early rapid ventricular refilling versus the late active contraction. Normal is less than 10 and more than 2 is basically indicative of highly restrictive filling. Prolonged deceleration time, that is the time taken from the peak filling velocity to the decline, and it's marker of the stiff, slow to fill ventricle. Prolonged isovolumetric relaxation time, the gap between the closure of the aortic valve and the opening of the mitral valve. And in the diastolic dysfunction, it is high. And the other supportive criteria were prolongation of the QTC, which it can be by the other drugs. So it was abandoned in the 2019 criteria, and last left ventricular atrium and the biomarkers. So there was a diagnostic shift from the 2005 to the modern criteria, which was basically dependent upon the tissue Doppler imaging and the speckle tracking echo. And the key metric was global longitudinal strain. This was the controversies which was surrounding the 2005 criteria, which was basically dependent upon the left ventricular ejection fraction, a decrease in SVR, with an artificially inflated left ventricular ejection fraction, and approximately 40% of the cirrhotic had chronotropic incompetence, that is the beta blocker downregulation. Hence, they were not able to mount an effective response to the stress. So there was a shift towards the resting echocardiographic assessment. There was an introduction of the subclinical systolic dysfunction via GLS, and there were more stringent diastolic dysfunction criteria which were used. There was a 2019 question defined as systolic and diastolic criteria, and coming on to the systolic criteria, left ejection fraction less than equal to 50%. And the main introduction was global longitudinal strain of less than equal to -18% was normal, and it was detected using the speckle trackled echographic. It basically are the longitudinal fibers in the subendocardium, and which is the area most susceptible to the ischemia and fibrosis. And there's a drop in GLS which is noted even before the drop in the left ejection fraction. The other criteria were diastolic criteria, and diastolic function basically now required 3 out of 4 parameter for the defining the diastolic dysfunction. Most important of which was septal E velocity, and it is the actual velocity of the myocardial tissue relaxing. It is a marker of early diastolic dysfunction. It is more load independent and reflects the true tissue stiffness. E by E dash ratio It is a non-invasive surrogate marker of left ventricular end diastolic pressure and the pulmonary capillary wedge pressure. It basically measures the ratio of the velocity of the mitral inflow versus the velocity across the mitral annular wall. Left atrial volume index, which is the volume of the left atrium at the end of the ventricular systole, and it is taken in measurement with the body surface area. It is also known as the HbA1c of the heart, and more than 34 is the cutoff, and it is a chronotropic marker of the chronic cumulative diastolic wall stress rather than the snapshot of the today's fluid status that basically indicates the chronic diastolic pressure overload. Then the tricuspid regurgitation peak velocity, also a marker of backward failures. This basically shows how to interpret the various echo findings. If the septal velocity is low, it indicates left ventricular relaxation is slow. If there is increase in E dash ratio, it indicates high left ventricular filling pressure. That is, the left atrium has to push hard and the patient is prone to develop pulmonary edema. And this basically can be important while pushing the fluids or the albumin, which basically predisposed to patient receiving albumin having flash pulmonary edema. Left ventricular volume index, it indicates long-standing elevated filling pressure, and it is an indicator of chronic diastolic dysfunction. Increased TR velocity, how the pressure is transmitted to the pulmonary circulation. And this basically is responsible for the symptoms such as dyspnea or post-transplant hypoxia risk. This shows the diagnostic algorithm for the diagnosis of the cirrhotic cardiomyopathy. First step is basically to exclude the other cardiopulmonary diseases. Step 2 is to assess the systolic function, whether the left ventricular ejection fraction less than 50% or global longitudinal strain is less than -18. Then comes to assess the diastolic dysfunction, which is basically left ventricular volume index, E dash, septal velocity, E dash velocity, or TR velocity. More than 3, we are confirmed with the diagnosis of cirrhotic cardiomyopathy. More than 2, it is indeterminate, and we can move towards stress echo or a cardiac MRI. This basically showed how moving from 2005 to 2019, this basically decreased the sensitivity, how the specificity was increased. There was E by A ratio was replaced by the tissue Doppler. There was non-specific QTC ratio was removed, and there was removal of the blunt stress response. This was a study by Span et al., which basically showed that the new criteria had better predictor of predicting the major adverse cardiovascular event post the liver transplant. However, it was not predicted by the 2005 criteria. Septal E dash is the most important single echo predictor of predicting the major adverse cardiac event post the transplant. I have discussed earlier how the new criteria affect the prevalence of the cirrhotic cardiomyopathy. There's a decrease in the diastolic dysfunction by new criteria from 70 to 30%. However, via the systolic dysfunction, there is an increase from 5 to 20%. This basically summarizes the difference between the old and the new criteria. The old criteria was more a functional circulatory change. New criteria is a true myocardial disease. Main abnormality in the old criteria was diastolic dysfunction. In new criteria, it is systolic dysfunction plus advanced diastolic dysfunction. It measures the left ventricular ejection fraction at less than 55% response to stress. However, the new criteria is based on more of systolic dysfunction, global longitudinal strain, which appears earlier than the decrease in the left ventricular ejection fraction. More of diastolic dysfunction criteria have been included. The QTC prolongation has been removed. Stress echo is not longer required for defining the cirrhotic cardiomyopathy. It is more specific, however, maybe less sensitive. And the prognostic value of the new criteria helps in predicting the post-TIPS and post-transplant cardiac event. Coming on to the clinical manifestation, which are seen with the cirrhotic cardiomyopathy, it is usually asymptomatic up to 50% of the time. Fatigue and exercise intolerance are the most frequent reported symptomatic complaint. Dyspnea is highly prevalent. Peri- uh, Peripheral edema, palpitation, and arrhythmia, or there is a risk of acute decompensation of the heart. Acute heart failure can be seen post-TIPS or post-transplant. These are the conventional biochemical or the electrophysiological marker which have been used for cirrhotic cardiomyopathy, namely NT-proBNP. NT-proBNP more than 295 has been suggestive. 295 has been suggestive of cirrhotic cardiomyopathy. And however, with renal dysfunction in the severity of ascites, there can be falsely high NT-proBNP in cirrhotic patients. Troponin I elevation up to 6 months post transplant can be highly sensitive to predict the post-transplant cardiovascular event. QT prolongation, however, has been removed in the new criteria, but QTC more than 47 has been associated with increased arrhythmia and the cardiovascular events. This basically shows the association of anti-proBNP with the high risk of cirrhotic cardiomyopathy. These are the conventional drugs which have been used for the cirrhotic cardiomyopathy, namely beta blocker. They decrease the sympathetic overactivity, decrease the heart rate and the portal pressure, and they help by reducing the hyperdynamic circulation, improving the left ventricular diastolic dysfunction, and decreasing the risk of variceal bleeding. ACE inhibitor, they decrease the RAS activation. They have some antifibrotic effect and decrease the afterload, and can be of therapeutic benefit in reducing the myocardial fibrosis and afterloads. Similarly, mineralocorticoid acts, they have some natriuretic and the antifibrotic effect, and can reduce sodium retention and may help in reducing the myocardial fibrosis. Coming on to the special scenarios which we'll see with cirrhotic cardiomyopathy, namely TIPS, transplant, and ACLF. So TIPS, as we know, can be emergency or elective in refractory ascites or bleed. With TIPS placement, there is shunting of there is shunt of the blood to the heart, and this splanchnic blood bypasses the liver, and there is an increase in the venous return of the right atrium. There's an increase in the cardiac preload, workload, and there's an acute hemodynamic stress on the heart. How the normal heart rate will respond? There's an increased beta adrenergic response. There is an increased contractility, increased stroke volume, and which help in maintaining the blood pressure. However, with cirrhotic heart, there's a blunted response to the beta adrenergic. There's impaired contractile reserve. There is inadequate cardiac output, and there is an increased left ventricular filling pressure, which increases the backward pressure to the lung, increases the risk of lung congestion and edema. There's forward failure of the kidneys, that is by the decreased renal perfusion, which can cause more of AKI, a persistence of ascites, and increased mortality. A ratio of less than 1 post 28 days of TIPS has been associated with lower survival rate. They have been reported in 2 studies. And preoperatively, E by A more than 2 indicates grade 3 diastolic dysfunction, and TIPS is usually contraindicated. E dash more than 15 is indicative of more of left ventricular elevated diastolic pressure. The TIPS is contraindicated, and enlarged left atrium, that is the size of the left atrium at the end of the ventricular systole by body surface area more than 34, and E dash ratio of more than equal to 11 is a red flag for TIPS. So coming on to transplant and cirrhotic cardiomyopathy, during transplant there are 3 phases. One is the clamping of the inferior vena cava portal vein, which slashes the venous return. And the empty heart is not able to mount a compensatory tachycardia due to the beta receptor downregulation, and there's severe intermediate intraoperative hypotension. Then comes the phase of reperfusion. There's unclamping leading to a sudden unleash of wave of cold acidotic blood into the heart, and the stiff fibrotic heart may not be able to distend to accept the volume surge, and it may basically cause instant diastolic collapse and acute right-sided heart failure and post-perfusion syndrome. Then the new liver phase, the new liver is able to clear the vasodilator abruptly, spiking the systemic vascular resistance, and the weak heart, which is usually accustomed to low systemic vascular resistance, is is failing against this sudden increase in the afterload, which basically may lead to the venous congestion of the new graft. So this basically predisposes to the increase in the post-operative and the perioperative cardiovascular mortality. How this CCM responds to the post-transplant. There's two component, which is one is reversible, which can be seen in up to 40 to 60% of the patient, and there's a reversible component of the systolic reserve and the electrical and the vascular mechanism, and the hyperdynamic state resolves, and there is normalization of the prolonged QTC. And the beta blocker, the receptor, they recover and restoring the normal heart response to the stress. However, the structural fibrosis, which was present pre-transplant, it remains and it causes a permanent damage, and the stiff ventricle may not be able to fully relax. And then drugs and the metabolic syndrome post transplant may attribute to more cardiovascular mortality. The reversibility of cirrhotic cardiomyopathy can be seen in up to 34 to 57% of the patients. The cardiovascular mortality, they account for 7 to 21% of the post-transplant death, and the removal of the cirrhotic liver, it eliminates the toxic metabolites. However, surgery is itself the ultimate stressor for this liver. So coming on to how the phenotype is changing from the chronic to the acute for cirrhotic cardiomyopathy. There's we see ACL very commonly. It is characterized by the cytokine storm, which is and profound systemic inflammatory response syndrome. There's a massive release of PAMS, DAMs, leading to surge of the inflammatory cytokines. There's acute myocardial depression secondary to the cytokine storm, leading to beta receptor downregulation and suppressing the contractile reserve of the heart. There's profound vasoplegia. This basically predisposes to type 1 cardiorenal syndrome, resistance to the vasopressor, and there's explosion of the biomarker, which is seen in the ACLF patient. The NT-proBNP and troponin can be very high. This has the clinical consequences of acute hypoperfusion of the kidneys, and despite having high doses of norepinephrine or terlipressin, we're not able to adequately generate the mean arterial pressure. This basically shows in how in cirrhotic cardiomyopathy and ACLF the standard isocare fail. The liver is not able to, the heart is not able to push the blood, and we push the albumin, leading to for the acute kidney injury or any other indication, and it may predispose to flash pulmonary edema. Pushing terlipressin or norepinephrine may not be able to raise the blood pressure, causing the acute pump failure, and then we have to use the pump, basically inotropes such as dobutamine to help the pump. And there can be switching to the dynamic monitoring, such as POCUS and venous exploration ultrasound, which may help in better predicting the portal and the venous congestion in the renal blood flow and stopping the blood flow before the lungs flood. This basically shows how the chronic and the acute cardiomyopathy differs. The conventional is basically is a chronic cirrhotic cardiomyopathy. However, we can see acute on chronic liver failure associated acute cardiomyopathy. The prime driver in the chronic one is the fat inflammation, insulin resistance. It is usually outpatient and characterized by the increased stiffness of the heart and the vascular channels. In ACLF, it is acute. There's surge of inflammatory cytokines, usually seen in ICU, and can cause acute severe vasoplegia. It is fibrosis, irreversible, slow. It is acute, potentially reversible. In EMA, there can be thickened epicardial fat, which can be seen. There is in ACLF, there is acute drop in global longitudinal strain or left ventricular ejection fraction. There can be systolic failure. The biomarkers usually are galactin 3 and FGF21. In the acute, the inflammatory marker or troponins can be used as the biomarkers. So coming on how to work up a patient pre-transplant. Coming on to the algorithmic approach, how to screen a patient for a liver transplant. The phase one is initial screening and triage. Universal baseline is basically to have a detailed history, physical examination at lead ECG, echo, identifying the risk factor, namely age more than equal to 50, male, diabetes, MASH, other comorbidities. If there's zero risk factor, we may proceed to listing, more than equal to proceed to phase two. Then cirrhotic cardiomyopathy protocol, echo, evaluating the global longitudinal strain or the diastolic dysfunction. If it is less than 18% or severe diastolic dysfunction is present, high intraoperative risk halt. See if it is inconclusive, we may go for conventional CT, conventional coronary angiography, calcium scoring. The calcium scoring more than 400, we should refer the patient for invasive angiography. If DSC is used and it is unconventional, we should proceed to CPET or the CT angiography. Pathway B can be to basically measure the stamina, which can be with the help of a 6-minute walk test. Less than 250 is usually indicative of severe frailty, mandate prehabilitation and CPET, and more than 400 is indicative of good reserve. CPET testing can help in basically deciding the patient, the stamina or the stamina of the patient. VO2 less than 11 ml per kg per minute is usually very poor, and patient should be halted and prohibitive risk for the liver transplant. More than 15 we should clear for transplant. These are the various variables which are used for the pre-transplant cardiac scoring. Global longitudinal strain, left ventricular ejection fraction EE dash, left atrial volume index, biomarkers such as anti-proBNP and high sensitivity troponin QTC interval, MELD score, right ventricular dysfunction, and age. And this is the scoring, which and score more than 7 based on these is indicative of high probability of post-reperfusion syndrome. DSC we commonly use here. It has advantages and some limitations. So I'll just mention in brief. DSC unmasks the contractile reserve, identifies the blunt systolic response, which is hidden by the low afterload at rest. It is very important in judging the dynamic obstruction, that is the latent left ventricular outflow tract obstruction or the systolic anterior motion. It can simulate the stress of the surgery, mimicking the sudden sympathetic surge and the catecholamine surge. It is renal safe. However, it is poor in identifying the CAD. In 40% of our patient can have chronotropic incompetence, and they are already hyperdynamics, may have ceiling effect, so it may not offer any additional squeeze. And there is a high risk of Torsades de Pointes or in patient with baseline QT prolongation. So when the DSC is inconclusive, if you're suspecting so coronary artery disease, proceed for CT angio or invasive angio. If you want to check the contractile reserve, global longitudinal strain, surgical endurance, cardiopulmonary exercise tolerance, volume tolerance, site heart catheterization, and boluses of fluid to measure the left atrial volume index. So coming on to the neotherapeutics, the neotherapeutics which are used in cirrhotic cardiomyopathy, drugs such as ivabradine, which is a selective IF channel blocker, reducing the heart rate without affecting the contractility. Then there are antioxidant mitochondrial stabilizer, reducing the bile acid induced oxidative stress. So taurine, albumin may help as an endothelial stabilizer, binding the pro-inflammatory ligands. FXR agonist may help in modulating the bile acid signaling to reduce the myocardial damage, and modulation of the gut biota and improving the cirrhosis dysbiosis ratio and the gut barrier integrity may help in making the cirrhotic cardiomyopathy better. New biomarkers such as galectin, ST-T2, MIR 155P, and lipopolysaccharides may help in identifying the patient earlier. And then there can be AI-driven prediction of CCM. There is a recent paper which was published on the ECG of the decompensated versus a compensated cirrhotic, which help in predicting the further decomposition with the area under the curve of 0.93. Then there can be automated GLS algorithm, which may help in identifying the patient earlier. And by there can be predictive modeling by feeding the 2019 criteria biomarkers and the inflammatory cytokines into the neural network. So and I'll just finish off with mentioning the limitation of the 2019 criteria. It basically focuses on the left ventricular mechanic. However, there should be an inclusion of the right ventricular free wall strain. There can be inclusion of the cardiac magnetic resonance, and which may help in quantifying the fibrosis and the extracellular volume. It is basically a static resting echocardiogram, including of the dynamic assessment such as passive leg rest coupled with echo may help in identifying the patient handling of stress better. Introduction of galectin-3, SST2, FGM, another fibrotic marker, and a nephritic peptide into algorithm. AI-driven approaches and identifying the different phenotype may help, and the introduction of the drug based on the phenotype of the cirrhotic cardiomyopathy may help in helping the cirrhotic cardiomyopathy patient. These are the various trials which are currently running on cirrhotic cardiomyopathy. One is carvedilol versus simvastatin, carvedilol plus ivabradine, GLP-1 receptor agonist, SGLT2 inhibitor, and the POCUS-based resuscitation versus standard care in patient who present with ICU and shock in fluid management. So to conclude, initially, it was to recognize the abnormal circulation. Present is to diagnose the systolic and the myocardial dysfunction, and the future is to predict and prevent the heart failure. Thank you.
We know then it's not easy for anyone to comprehend, but you did highlight many things. I only have one question. Are beta blockers good? We have done this study, beta blockers plus ivabradine. So any more data on carvedilol benefits in CCM?
In initial stages, it does serve by reducing the hyperdynamic state. It does help, sir. But in the later stage, then we should move from the non-selective beta, basically from carvedilol to propranolol, sir, in the later stages, which may help in decrease risk of this renal events and the less kidney AKI in the future, sir.
The comments from Dr. Sood, sir.
Good morning. Dr. Vinod has covered all areas very well. So first of all, we should know that CCM is a subclinical diagnosis. Most of the patients, they don't have any symptoms, and recognition is only by the investigations. Number two, if we see the American Heart Association has given 4 stages of heart failure, A, B, C, D. A is the one with risk factor, but nothing. So all patients diabetic hypertensive are classified as a class A heart failure. I think cirrhosis should, maybe the chronic CLD should also be included in that, but at the moment it is not. B is the one with no symptoms, with structural heart disease either by ECG or echo, and CCM fits into that. The third is with symptoms and structural problem. The problem with CCM, the symptoms are mostly the same. I mean, the swelling and all that. So we mostly miss that. So, and D is the one with the advanced heart failure. The importance of CCM is, he has shown us in transplant and all that. And I think that's all. He has covered it very well.
Okay, thank you, Vinod. In the interest of time, thank you. Okay.
Thank you, Vinod, for nice lecture on a difficult topic. Now I am going to speak about the tips, that is transjugular intrahepatic portosystemic shunt for patient on liver transplant list. So my task is to identify ideal patient who will benefit from the tips in pre-transplant setting and what is the ideal window of time. So as we know that cirrhotic patient are often develop portal hypertension related complication and decompensation while on waiting list. Most common complication are ascites, bleeding, varicose bleeding, and sometimes portal vein thrombosis. And role of tips is to control this portal hypertension complication, not to replace the transplant. So in cirrhosis, because of the increased portal pressure, all of the organ are affected direct or indirect way. So these lead to decreased nutritional status of the patient or many comorbidities. This is one of the study which show that risk of portal hypertension related complication is much high if patient is having grade 3 ascites with either sodium less than 130 or MELD more than 12. So this high risk patient can be prevented by portal hypertension related complication by introduction of TIPS in such patient. So TIPS is a percutaneously created shunt between portal vein and hepatic vein. So goal of TIPS is to reduce portal pressure by shunting part of the blood from portal to systemic circulation. So benefit of TIPS is to reduce portal pressure and it related complication, and with this it improve the nutritional status of the patient in pre-transplant time and also maintain the transplant feasibility for longer duration of time. Most indication in pre-transplant setting for the TIPS is the refractory ascites when patient not when ascites is not mobilized with the highest dose of diuretics and may require repeated large volume paracentesis. So if we do TIPS, it improve the ascites control and improve the nutritional status of the patient. Second common indication in pre-transplant setting is the high risk varicose bleeding. If endoscopic and medical management not able to control the varicose bleeding, sometimes TIPS also useful for portal vein thrombosis to recanalize the portal vein, and in some scenario it also useful for the hepatic hydrothorax. So impact of the TIPS in pre-transplant patient is that it is beneficial because it reduces the transfusion requirement at the time of surgery. It recanalize the portal vein, so decrease the complexity of the surgery. It also improve the ascites control, so there is less decrease in nutritional stress of the patient. However, there are some technical concern it increased the technical complexity of the transplant surgery because of the extension of the stent into IVC and because of the cardiac overload by the shunt. So which patient is ideal or benefit from the pre-transplant tips? As the liver disease severity increases, the benefit of the tips is decreased and risk of the complication is increased. As highlighted by this study, that as the Child-Pugh score and MELD score of the patient, as well as the age of patient is increases, then benefit and risk are equal at the middle time, and at later on, benefit are decreased and risk are increased. So patient who benefit most are patient with MELD less than 18, patient with bilirubin less than 3, patient with sodium more than 30, especially for the refractory ascites. When we can set high risk for the tips, if patient is having MELD more than 22 or bilirubin more than 4, and patient already developed severe hyponatremia or severe sarcopenia. And this is true for the refractory ascites. So MELD is a good predictor to assess the liver function status as well as the post-tips survival. So if MELD is less than 18, then we can go ahead. If patient is having MELD 18 to 22, then if patient is in good shape, no comorbidity, no sarcopenia, we can opt for tips. If patient is having MELD more than 24 or any symptom of severe sarcopenia with MELD more than 18, then we should avoid tips in such patient. This is the recent guideline published in European Association Society of Liver Disease. According to this study, tips is useful for refractory ascites, and they also consider that we should discuss tips early to improve patient outcome for refractory ascites. So they also advise that we should do tips early. European Association also advise tips for portal vein thrombosis if patient is having progressive PVT, patient on waiting list for the transplant. American Association guideline also advise tips for refractory ascites and high variceal bleeding, especially in high risk patient, that is patient having Child-Pugh C score or Child-Pugh B with active bleeding. Baveno guideline also recommended use of tips in 3 settings as a preemptive tips, that is early tips for high risk variceal bleeding, rescue tips if bleeding is not stopped by the endoscopic therapy, and as a secondary prophylaxis. So goal of this all guideline is to decrease the decompensation in the patient. Baveno guideline also say that tips is not used if patient is having MELD more than 14, Child-Pugh is more than 14, MELD score more than 30. In such scenario, only tips can be advised. A very short term we can plan tips transplant. This is the recent guideline. These guideline also say that tips is considered for all patients with more than 3 LVP. And they also recommended that tips should be considered early in history of disease to improve transplant-free survival. So summary of this evidence guideline is that for refractory ascites, European Association and American Association guideline recommended tips as a bridge to liver transplant. For high risk variceal bleeding, American Association and Baveno guideline recommended tips to prevent deterioration in the patient. For progressive PVT, European Association and Baveno guideline recommended tips to facilitate the surgery. Timing of tips is important because we should do proactive tips, that is early tips before patient develop repeated decompensation and decrease nutritional status of the patient, and patient develops severe sarcopenia. In such patient, there is high risk of mortality. Or if patient is on high inotropic support, then also there is high risk of post-tips mortality. And if patient is developed high advanced liver disease, then there is also a high risk of post-tips liver failure. This is the paper which compare the tips versus large volume paracentesis. And this is the prospective study which show that at 1 year, tips group show survival at 93% patient and LVP group show for 52% survival. So by introduction of tips at an ideal time, we can double the survival in pre-transplant setting. This is another study which highlight the importance of lower paracentesis frequency on post-tip survival. In this study, post-tips patients are divided into ascites control and persistent ascites. And their results show that ascites control by TIPS is more successful in patient with lower paracentesis frequency patient. And this patient also show more survival as compared to patient with high paracentesis frequency. This is another study which highlight the importance of TIPS in improving the quality of life of the patient. And according to this study, quality of life is improved on visual scale significantly from 35 to 64 at 3 months and 66 at 6 months by introduction of TIPS. If we do TIPS early, then this quality of life improvement is more. So TIPS improve ascites control, TIPS reduces the rebleeding rate. Post-TIPS patient require fewer hospitalization because of the portal hypertension related complication. It improves the nutritional status of the patient, and there is no obvious adverse impact on post-transplant survival outcome because of the TIPS. This is the study which show that TIPS is associated with better waitlist management of liver transplant candidate with HCC. According to this study, patients who underwent TIPS show more survival as compared to without TIPS while on waiting list. Another interesting finding of this study is that patients who underwent TIPS show less chances of HCC recurrence as compared to patients without TIPS. This is another study. This is basically a registry data of 97,000 patients. And this study also show that association of TIPS is with the pre-transplant survival. And according to this study, patients who underwent TIPS show less chances of death as well as the less chances of transplantation on follow-up. The approx hazard ratio of 0.86, that is approx 16% decreases the chance of death as well as requirement of TIPS on pre-transplant waiting time. This is another study which highlights the importance of TIPS on Budd-Chiari syndrome patient survival. According to this study, patients with TIPS show less waitlist dropout, that is less death of this patient as compared to without TIPS. And patient with the TIPS also required less transplant requirement on follow-up. This is another study which also highlights the importance of TIPS in SLK pre-transplant waiting time. And according to this study, patient who underwent TIPS has less chances of death as compared to patient without TIPS. Another important indication of TIPS in pre-transplant setting is for the portal vein thrombosis patient. As the portal vein thrombosis develop, it complicates the surgery and it increases the operative time as well as blood loss, and overall outcome is less. This is the most widely used classification system for the portal vein thrombosis. If portal vein is occluding less than 50% of diameter, then it is a grade 1. If portal vein thrombosis occluding the more than 50% or complete occlusion of MPV, then it is grade 2. If it extending up to the proximal SMV, then it is a grade 3. If extending up to the distal part of SMV, then it is grade 4. So as the grade of PVT increases, the complexity of surgical technique which required during the transplantation also required, and normally from physiological to non-physiological anastomosis are required. And overall outcome also decrease as the grade of the PVT increases. So role of TIPS is to maintain the portal vein patency, decreases the complication which developed by the PVT, and convert the complex PVT into transplantable anatomy. And ideal patients are those who have chronic PVT or acute on chronic PVT which are not cleared by the anticoagulant. This guideline also recommended that TIPS has a role in cirrhotic patient with PVT who or cavernoma formation which are on the waiting list, and this guideline recommended that patient with cirrhosis and complete PVT or cavernoma which progresses despite anticoagulation, TIPS creation and PV are recommended to facilitate access to liver transplant and enable physiological portal vein anastomosis. So by introduction of TIPS at the ideal time, we can increase the surgical feasibility. American Association guideline also recommended PVR TIPS for the acute and chronic PVT. And according to this guideline, technical feasibility can be achieved from 70 to 100%. depend upon the expertization of the TIPS center. This study included the 28 patients of the PVT which are otherwise contraindicated because of the portal vein thrombosis for the liver transplant. And out of this 28 patients, 25 patients underwent attempted for the PVR, and technical success was achieved in 24 patients. And on follow-up of these 24 patients, 16 patients underwent liver transplant in a normal physiological anastomosis. 3 patients are delisted because of the improvement in the condition of the patient. 2 patients died on waiting list, and 3 patients are still on the waiting list. So significant improvement of the outcome of PVT patient by introduction of the TIPS. This is another study which highlights the importance of the TIPS, that 35 patients, cirrhotic patients with occlusive PVT are underwent PVR TIPS while on awaiting liver transplant. And in this study, portal to portal anastomosis was achieved in 91% of patients. So normal physiological anastomosis was achieved in this 91% patient. TIPS also helpful in post liver transplant on the if patient develop graft liver failure prior to retransplantation, as highlighted by this guideline. The TIPS insertion is feasible and may be considered after liver or standard after failure of standard treatment and as a bridge to liver retransplantation. So prior to liver retransplantation, we can attempt TIPS. Post-TIPS management also important because there is always a risk of HE, and if we treat this HE at an appropriate time, then decompensation is decreased. Continuous surveillance of TIPS stent also required to decrease the chance of portal hypertension related complication because of the stent blockage. If continuous liver parameter are deteriorate, we may require upgrading of the liver transplant listing. This is the study which highlight the effect of the MELD after TIPS, and this study show that MELD is a good predictor for long-term outcome after TIPS. According to this study, if MELD is stable after TIPS, even if the MELD is high or low prior to TIPS, then this patient show long-term survival. However, if patient is showing increased MELD after TIPS, then this patient show less chances of survival. So we can do early transplant in such patient. We may require different technical modification at the time of TIPS to decrease the complexity of the transplant surgery. We should avoid extension of the stent too much into the portal vein as well as the IVC. We should use covered stent to decrease the chance of the stent blockage. We may require different diameter of stent to decrease the chance of the liver failure post-TIPS according to MELD score or liver performance status. This is the study which highlight about the optimal threshold we should achieve after TIPS to decrease the chance of liver failure. According to this study, if post-TIPS PPG is less than 7, then there is always a high risk of liver-related death. And if post-TIPS PPG is more than 11, then there is a high risk of recurrence of the portal hypertension-related complication, that is ascites. So post-TIPS PPG of 7 to 11 is good if we can able to achieve. This is another study which highlight that post-TIPS PPG reduction of 60 to 80% is good and shows significant reduced chances of hepatic decompensation without any increased risk of HE. So 60 to 80% reduction is achievable. We can do this scenario to create such type of TIPS. So I conclude my talk by saying that TIPS is valuable procedure as a bridge to liver transplantation when planned in a carefully selected patient. If we plan TIPS for the ascites, MELD score up to 20 safe. If for the variceal bleeding, we can go up to 25 MELD. Early TIPS before patient develop severe sarcopenia improve the outcome. And if we plan late TIPS, then there is a high risk of complication. Thank you.
Very nice, Yashwant. I am very interested in one. There is a decrease in the SLK patients for need for SLK. Can you go back to that slide that tips can decrease SLK need? Can you explain this?
This the study highlight the importance of tips in pre-SLK setting. This is the cumulative incidence of death, and this is the month of on waiting list time. This dark line is tips patient, and this with less dark line is no tips patient. So approx 12% chances of decrease in the death in the patient who are under with the tips, and 9% as compared to 9% of the.
Till what level of creatinine were they including patients? Like were they on dialysis, hemodialysis, or what was the CKD stage?
These all their liver but kidney function is not improved even if the medical management, and they fit for SLK, but they are planned already on the same, both on dialysis as well as.
We are very scared of getting tips in this, and there is a large number. Maybe we should explore this area. Any other comments?
Yes, sir. Yes, very nice presentation. Really enjoyed it. The slides were very good, very informative, very good presentation to be honest. But I got a one problem with this. If you go to your initial slides on paper from Journal of Hepatology, where you got 3 areas on, right? Initial slides. I think they were first. Yes. So this, yeah. So if you look at this, because this is where you have drawn conclusions as well. Your conclusion has come from this slide. And I think your subsequent after this, there are 4 or 5 slides which are going on based on this paper, right? So you're saying 18 med, right? This slide actually doesn't say 18 med. The risk here, 12 to 18, risk benefit, both 2 plus, equal benefit risk, right? It is 12 to 18. It is not 18. And there is a hell lot of difference between a MELD of 12 and MELD of 18. So that's a wrong interpretation of data actually. The benefit is 3 plus is less than MELD of less than 12, not 18. So we need to be very careful, because why this is, I'm saying, and you're drawn the conclusion from that as well. Your last conclusion slide says MELD more than 18, less, 18 to 12. So you need to be very careful about this. In a sarcopenic refractory ascites patient with a MELD, this MELDs are very dramatically actually influences survival in this group of patient, because they don't build creatinine. They all lost muscle mass. Once you develop refractory ascites, there is no creatinine in the play actually, honestly, but in the chronic liver disease, because the muscle mass is gone, no creatinine is coming into MELD. So that MELD actually, when you change from 12 to 18 in a refractory ascites, it's a very dramatic change in his prognosis. So we need to be careful in terms of interpreting this data.
Agree with what Vinay is saying, and I was also expecting some data and an algorithm, and especially since the surgeon is here, how much challenge, because I reviewed 2 papers and both said that TIPS is now being considered as a bridge so that the post-transplant outcomes are better and the heart failures are less. So what is your thought? Is doing TIPS, is it comfortable to do LT after that? Number 1. And number 2, should we think more of TIPS before transplant?
Is that for me?
Yeah.
So I don't think doing transplant after TIPS is a problem. I don't think that's a problem. So because we've done few, and it's only, as Yashwant has highlighted, that you need to be careful where the stent is. So it should not come into the right atrium. That's one important thing. And it is also not going down into the too much downwards as well. So that's the issue with TIPS. But in general, I think technically it is not a problem.
Not a problem. Is it-
And some of the indication like type 4 portal vein thrombosis, if they can recanalize, you can actually have more physiological sources of using portal flow. So there are advantages there as well. So no doubt there is advantages, but in terms of, because when we are dealing with patients like this, refractory ascites, and because what happens is when you do TIPS and then there is further delay, the sarcopenia doesn't change as well, and it's just So
Yashwant, can you go to your last slide and then we conclude, very last slide where you have made recommendations. Uh, so, yeah, so I think MELD of 18 is comfortable, 20 varicose bleeds. Yeah,
sir, this is what it is. 18.
Yeah.
That slide,
Sir,
Journal of Hepatology paper doesn't say 18. It says
Just a
12. It
many
says
new
12,
papers,
18
many new
to 20,
papers.
the risk benefit is not shown there.
Yashwant,
let's,
and-
I want ask, is my experience of this 12 years in ILBS. Initial time when all diuretics are of one line only, no amyloid or other are available. Patient are shifted for tips early of MELD 14, 16. We are happy with the placement of 10 mm stent and good outcome. As the patient are come with the late diuretic state, we have change our modification. We now place 6 mm, 8 mm stent. So overall complication rate is not significantly decreased. A change is same. We change our technology. It is depend when patient will go to transplant. So our time is only to buy patient some time from the portal hypertension complication. We don't change the patient from the transplant to transplant.
good paper that if the liver volume is less than 900 ml, use 6 millimeter, more than 900, maybe 8 millimeter, and for bleed 10 millimeter. But anyway, thank you, Yashwant, and hope we have more guidelines and discussions on this. Thank you.
Thank you.